scores. Now, this assesses the patient in two categories, whether the patient is at high risk or at risk of malnutrition, or whether the patient is well nourished. If the patient is well nourished, we go for a regular assessment tool, like for example, SG, and calculate the calorie requirement and plan the nutrition regime. Wherein if the patient is a high risk patient, as we use a GLIM criteria to further evaluate the patient, which can be done into two categories, which is phenotypic category and etiologic criteria. Sorry. So in phenotypic criteria, what we look for is how much the muscle loss has happened, weight loss has happened, what is the BMI of the patient. Wherein etiologic criteria, it sees the disease burden, what are the medical complications, and whether there was a decrease in food intake or not. Uh, if the patient is high risk and there has been weight loss, there's been muscle loss, we can diagnose it, or we can kind of assess this by various tools, like doing a strength assessment by hand grip, for example, by doing imaging of CT, MRI, and also by other anthropometric measurements. Once this is done, we are able to diagnose if the patient has got sarcopenia, and then accordingly we do the assessment and move ahead with the planning of the nutrition therapy. Now, the second, after we assess the patient for risk of malnutrition, the second step is translating guidelines into bedside care. So basically, what to plan, how to plan is everything that we need to know about. So this is this involves evidence-based practice. So it is very, very important that before, as a dietitian, we put a pen on paper to prescribe nutrition regime. It is we know the guidelines, we know what our practice is based on, and these could be taken from international guidelines like ISPEN, and Canadian, etc. Now, what they say about parenteral nutrition is parenteral nutrition should be withheld in critically ill patients who are low nutrition risk for at least the first 7 days. So if the patient is got admitted, you assess the patient, and the patient is a low risk patient, then you can try for oral and enteral and give it a time of at least 7 days before you decide on starting with parenteral nutrition. So for that, conducting a full feasibility of enteral route is very, very important. Initiate PN if EN is not feasible even after 7 days of admission. So you've tried on enteral nutrition, but you fail, and then there is no option of starting enteral, or there's no option of gut availability, then you go for parenteral nutrition. In high nutrition risk or severely malnourished critically ill patients, initiate parenteral nutrition as soon as possible. That could be within 3 to 5 days of if EN is not feasible. Supplemental parenteral nutrition should be considered in case patient is not receiving required energy protein, which is less than 60%, even after 7 to 10 days of admission. Delay PN in patients with severe metabolic instability and until improved. This is very, very important. Initiate lower hypocaloric dose. This should be used as a principle for our practice, that if the patient is a high risk patient, to start with as low as 20 and lesser kilocalorie per kg per day, and a protein of around 1 to 1.2 grams per kg per day to prevent risk of insulin resistance, hyperglycemia, and increase progressively when patient stabilizes. Emulsion should be generally a part of PN. These are lipids that we are talking about. Avoid soybean oil-based lipid emulsion in critically ill patients who are not malnourished or need for a short term. Now, why do we say that is something that I'll discuss later when we talk about lipid emulsions. Next is blend of MCT, olive oil, fish oil is available to lower the inflammatory effect of omega-6 is advisable. Now, second is after understanding what the guidelines are, when to start PN, the next important step is to create or develop a protocol. The protocols can be as per your facility, as per the hospital specific needs. So it could be a flow chart which says what kind of supplement parenteral nutrition bags are available, which ones to be given via central, to which one to be given via parenteral, And how to go about it, it could be to help your subordinate to nursing staff, because it's a multidisciplinary team which is working here. So formation of that team is very, very important. No one person can do all of this together, so it has to be dietitian, pharmacist, physician, and nurses together. uh, then comes prescription. So once you understand the guidelines, then is the prescription. And as dietitians, the very first thing that we learn when we plan a diet is that there is no one diet that fits all, which same applies in parenteral nutrition. So it has to be individualizedly calculated in terms of macro and micronutrient. And specific needs should be addressed, like patients who are kidney disease patients or have liver dysfunction, etc. Advocate for dietitian order writing privileges to reduce delays and transition errors. So very, very important that dietitian understands so that they can write order to initiate nutrition therapy as soon as possible and effectively. So there are different methods of calculating the energy need. Nowadays, most of the guidelines say indirect calorimetry is considered as the gold parameter, a gold instrument to calculate the calorie requirement of critically ill patients. This is the calories calculated on the principle of resting energy expenditure. But I understand that a lot of facilities don't have indirect calorimetry access. So then in those cases, equations like predictive equations like calculating the weight with the 20, 25 or 30 kilocalorie per kg, or using a Herrick-Benedict equation can also be done. So types and composition of formulas available. Once you know how much calorie, protein, how much carbs and amino acid is to be given to patient, we need to know how to give it, what kinds of formulas are available. So parenteral nutrition formulas are classified based on how they are prepared, their administration route, and their specific nutrient composition into customized, standard or pre-mixed and specialized. So customized is something that Dr. Chitra ma'am spoke about, that in earlier days, they used to mix different components together and make a formula to deliver nutrition to patient. Standard or pre-mixed are which are ready to use bag, like you can see here, 2 chambers or 3 chambers, or maybe a single component. And specialized is again as per disease condition. And now discussing about macro and micronutrient, first we go ahead with carbohydrates. So it is provided in form of dextrose monohydrate in a variety of concentration, mostly 40, 50, and 70%. Each gram of dextrose supplies 3.4 kilocalorie of energy. Now, this is very, very important to keep in mind when we are calculating the carbohydrate requirement, because it differs from that 4 kilocalorie per gram of carbohydrate that we do usually for oral feeding, dietary prescriptions. So here the carbohydrates that we are calculating is in the form of dextrose, and 1 gram of it provides 3.4 kilocalorie. The total grams of dextrose needed per day is determined by calculating the patient's non-protein energy goals, subtracting the calories from lipids, and converting the remaining carbohydrate calories to gram by dividing 3.4 kilocalorie. So maximum oxidation rate of glucose is approximately somewhere between 5 to 7 grams per kg per day. Exceeding this rate increases the risk of hyperglycemia that can put the patient at a risk of even more, infections like nosocomial infections. It can increase the carbon dioxide production, burdening the patient with respiration, and of course, hepatic steatosis, which is fatty liver. So in critical illness, those patients with sepsis, trauma, or on high dose steroid often have impaired glucose intolerance. So it is always advised to, when it is a critically ill patient, to start with a dose of 1 to 2 gram per kg per day, or lesser than 4 mg per kg per minute. So monitoring and consideration with carbohydrates is very, very important. These are blood glucose monitoring, because high infusion rate, because it is given in the form of dextrose, can lead to high sugar levels. Insulin infusion, depending on how the blood sugar levels are, insulin infusion is very, very critical. And in critically ill patients on parenteral nutrition, it is always mostly advised to put the patient on insulin infusion pumps rather than giving bolus. And then, of course, transition of PN. When you're removing patient or transitioning patient from PN to EN and then oral, it is important to look if the patient is going into hypoglycemia or not, because once you withdraw the delivery of dextrose, there could be sudden discontinuation can lead to hypoglycemia. Second is amino acid. So amino acids and protein, as we talk about, are never considered as energy source, but they are used as building blocks for protein synthesis that we know of, replenish nitrogen losses and prevent the breakdown of muscle tissues. Optimal protein intake is approximately 1.5 gram per kg per day when we are talking about critically ill patient. This amount of protein takes care of intake can decrease the degree of nitrogen loss in catabolic patients, mostly by enhancing visceral protein synthesis and to a lesser extent by diminishing peripheral protein catabolism. Now, these are available in two types. One is standard amino acid solutions. These basically consist of a blend of essential amino acid with non-essential amino acid and sometimes conditionally essential amino acid. So now, what is conditionally essential amino acid? We all know the amino acid which are ideally are either essential or non-essential, but becomes essential during phases of stress, condition of stress in critically ill patients. Now, availability, these solutions come in various concentration, most commonly 10 to 17. Higher concentrations are useful for patients on fluid restriction, suitable for metabolically stable patients without specific organ dysfunction, providing the necessary nitrogen to support protein synthesis. Now, the second type is specialized amino acid formulation. These are designed for specific need, for specific patients, for example, in case of hepatic insufficiency. Now, these formulas have a higher proportion of branch chain amino acid and reduce concentration of aromatic amino acid. The goal is to correct the plasma amino acid imbalance associated with hepatic encephalopathy. The other is renal, in case of renal insufficiency, these formulations are enriched with essential amino acid and are designed for non-dialyzed renal patients to limit nitrogen intake while preventing essential amino acid deficiency. However, guidelines also suggest that standard amino acid formulation can be used for these patients effectively. Then there are amino acid formulations for pediatric age group. Dosage and consideration. So protein need in parenteral nutrition vary widely depending on patient's condition. In stable condition, anything between 0.8 to 1.5 gram per kg per weight, depending on how the patient and how much it needs. And if the patient is critically ill, depending on the severity of illness, it could be anywhere between 1.2 to 2.5 gram per kg per day. In renal replacement therapy, it is advisable 1.5 to 2.5 gram per kg per day due to amino acid losses during dialysis. Monitoring again is very important. The adequacy of protein support can be assessed by either analyzing nitrogen balance. A patient in positive nitrogen balance is said to be in anabolism or retention, which is a good sign. And the other is blood urea nitrogen. So in case if it increases excessively, which is more than 100 ml per DL without clear signs of dehydration or renal failure, the protein infusion rate may need to be reduced. Third is lipids. These are complex formulation that provides, of course, a concentrated source of energy, essential fatty acids, and fat-soluble vitamins. These are again into different formulations, different forms. The first is standard soybean oil emulsions. These are also called as first generation lipid emulsions, like intralipid. Derived solely from soybean oil, as the name suggests. These are rich in omega-6 PUFA, primarily linoleic acid. The benefit is it provides a dense source of calories and supply essential amino 6 and 3 fatty acids to prevent essential fatty acid deficiency. The drawback is because it is high concentration of omega-6 fatty acid, it can promote inflammation and may have immunosuppressive effect in stressed patients. This is particularly concerned when we are talking about critically ill patients. So, moving on to next is multi-oil emulsions that are divided into 3-4 different types. These are called as second, third, and fourth generation respectively. So the first and foremost is SMOF, as the name suggests, is S stand for soybean, M is for medium chain, O is for olive, and F is for fish oil. So it's a combination of all these four lipids, and in different concentrations like 30, 30, 25, and 15 respectively. It is beneficial over using only soybean based emulsions, because olive oil here is rich in monounsaturated fats, which is omega-6, is immunoneutral. Neutral fish oil provides omega-3, EP, and DHA, which have anti-inflammatory properties. So this combination can mitigate the pro-inflammatory effects of pure soybean oil emulsions. And this MOF is something which is very, very readily or usually used in parenteral nutrition these days. So clinical use, widely used in critically ill and surgical patients and associated with lower infection rates and shorter hospital stay compared to soybean oil alone. Then the other is a combination of soybean oil and olive oil, which is 80% olive and 20% soybean oil. Has a lower omega-6 PUFA because there is a mixture of olive oil in 80%. So has less impact of immune function on immune function. The limitation is while it offers advantage over soybean oil, it does not provide the specific anti-inflammatory benefit because the omega-9 which is present here is, as I said, it is considered as immunoneutral. Third is MCT LCT emulsion, which is a combination of soybean oil with medium chain or long chain triglyceride, which is in the form of 50-50%, 50:50 mix. Offers a more stable emulsion with less PUFA content than more pure soybean oil, potentially reducing the risk of lipid peroxidation. It's used safely in critically ill patient, but has few immunomodulatory effects than fish oil containing emulsions because they are rich in omega-3. And now the last is fish oil emulsions. The composition is either in a mix, like in, for example, in SMOF lipids, or it is available in 100% fish oil emulsions, like, for example, omega-Vin. So benefit is it is rich in anti-inflammatory omega-3 fatty acid, EPA, DHA, which are known to reduce liver complication and aid in resolution of inflammation. Pure fish oil emulsions are primarily used to treat parenteral nutrition related associated liver disease, which is PNLAD, particularly in infants. These are they are only typically used as a sole source of lipids for long period as they lack. They are not typically used as a sole source of lipids for long period as they lack sufficient essential fatty acids. Now, this is a tabular representation of the the ratio of first, second, third, fourth generation lipids. So first generation, which is 100% oil, soy oil is 7:1 to 6 is omega-6:1. So 7 is omega-6 and 3 is omega-3. Oh, sorry, 1 is omega-3. Similarly, second generation, which is soy plus MCT, is 7:1. Then third is 9:1, and the fourth, which is used extensively in parenteral nutrition, is MOF, which has 2.5:1. Key monitoring and clinical consideration while dealing with lipids is that a minimum amount of ILE, which is around 1 gram per kg per day, is needed to prevent essential fatty acid deficiency. Monitoring triglycerides is very, very important. Infusion rate must be managed to avoid hypertriglyceridemia, which can lead to pancreatitis. The target level is typically less than 400 mg per dl during infusion. Anything more than a triglyceride level more than 1000 mg per dl, the patient is at high risk of developing fat embolism, hypersensitivity to lipid emulsions, severe metabolic acidosis, and patients with acute shock, anemia. This should be taken into consideration. Consider timing and patient status. Early initiation is advisable, but dose and type may vary based on patient's metabolic stability and inflammatory status. Since most complications when dealing with lipids is associated with the rapid infusion, so the rate should be initiated at around 0.7 gram per kg per day, which is supposed to be safer infusion rate. Now we understood about the macronutrients, carbohydrate, dextrose, amino acid, and lipid. Now we understand, well, how do we the base of calculation, how do we easily calculate that? So here is a hypothetical patient, which is like, and very, very bare minimum, not putting any complications here, but just the requirement. So 40-year-old female, weight is 60 kgs. Energy requirement is somewhere around 25 kilocalorie per kg per day. Carbohydrate requirement is calculated to be 60% of total calorie. Protein needed is 1 gram per kg present body weight, and fat is 25%. So how do we calculate the dextrose required for this patient? So if the patient is 60 kgs, we multiply by 25 kilocalorie, which is 1500 kilocalorie. So now 60% carbohydrate requirement of 1500 kilocalorie is around 900 kilocalorie per day as dextrose. So 1 gram of dextrose, as we discussed earlier, gives 3.4 kilocalorie. So simply 900 calorie as dextrose is divided by 3.4. So we get 264.7 grams of dextrose that we need every day. So not carbohydrate, but dextrose that we need every day. Now, how much ml of, for example, 50% dextrose solution should we give to get this amount? How much ml do we require? So dextrose 50% will have 50 grams of dextrose per 100 ml. So to provide 264.7 grams of dextrose per day, required volume would be into 100 divided by 50. That would be 529.4 ml per day. Similarly, how do we do amino acid? So 60 kg, 1 gram per kg body weight is 60 grams of protein. 5% of solution, 5% 100 ml solution will give 5 grams of amino acid. So 60 into 100 divided by 5 is 1200 ml of the 5% solution is of amino acid is required. How about lipids? 25% is what we need from for fat, as in lipids, of 1500 calories, so which is equal to 375 kilocalorie per day. Now, if I take a 10% of lipid emulsion, it gives around 1.1 kilocalorie per ml. If I take 20%, it gives 2 kilocalorie per ml. Similarly, 30 will give 3 kilocalorie per ml. So to provide 375 kilocalorie per day, required volume of 10% emulsion would be 375 divided by 1.1, which is 340 ml. So now these are the basic calculations how we do for dextrose and amino acid and lipid. But the nutraceutical companies, pharmaceutical companies have made it quite kind of easier for us. For example, like when we calculate, enteral nutrition formulas, it comes with though they are in huge range, it comes with all the standard, protocols and standard formulation that if you give one scoop, you get this much of protein. If you give one scoop, this is how much of fat. Similarly, the parental nutrition, formulations which are available have those, guidelines where they talk about how much level is giving how much calorie, what is the composition of carbohydrate, dextrose, amino acid, and lipid, and to an extent to how much ml per kg body weight can be infused. So this makes a bit easy while calculating. So next come immunomodulators. Glutamine, hugely discussed, immune modulator when we talk about critically ill patients. It is primarily energy source for rapidly dividing cells such as intestinal epithelial cells, vascular epithelial cells. It helps in maintaining the gut barrier and is known as fuel for immune system. It is most abundantly available but becomes conditionally essential during critical illness when the body stores are rapidly depleting. And the supplementation and parenteral nutrition has been a strategy to overcome this depletion in the stress state. Supplementation may help in maintaining intestinal integrity, immune function, oxidation synthesis, antioxidant synthesis, protein synthesis. Now, a systematic review study by Wishmeyer reported that the recommended dose for parenteral supplementation of glutamine is 0.2 to 0.5 gram per kg per day, which is in sync with what the international nutrition societies have to say. So, for example, if it is the same patient with 60 kgs of weight and I want to give 0.2 grams of per kg body weight of glutamine, so it would be around 12 grams per day. So highest would be around 30. So somewhere around 12 to 30 grams per day is advisable. As per, depending of course on case basis, as per recent guidelines like ISPEN, ISPEN, etc., parental glutamine is not recommended in critically ill, unstable, and complex ICU patients with multi-organ failure, especially with liver and renal function, renal failure. So when we are dealing with patients who are not stable and have got liver and renal conditions, we have to be careful about supplementing this. And researches and the guidelines says that it is not recommended. Glutamine supplementation is not typically initiated early in the acute phase of critical illness, which is 24 to 48 hours, but rather after the patient has been hemodynamically and metabolically stabilized. Now, the second very much discussed and supplemented immune modulator is omega-3 fatty acid. It becomes a key strategy for mitigating the heightened inflammation and oxidative stress. As we know, the property of omega-3 is to mitigate with the inflammation conditions. So the evidence says that it reduces infection rate. Meta-analysis published in 2019 found that omega-3 enriched parenteral nutrition supplementation significantly lowered the risk of infection in hospitalized patients, including those in intensive care. Shorter hospital stay, if we are taking care of the infection rate, in a way we can take care of the stay of the patient in the hospital. We can reduce the days. Improved inflammatory markers, we have been discussing this all along. Omega-3 fatty acid, including EPA, DHA, actively reduce inflammation by modulating the synthesis of inflammatory mediators like eicosanoids and prostaglandins. Potential for cost effectiveness. So if we see omega-3 enriched emulsions may be costly, but if they are beneficial, if they're benefiting the patient in many other aspects, it could reduce the cost of overall hospital stay and ICU stay. Better outcomes in specific patient groups is seen in post-surgery cases, which is linked to improved liver function and fewer infectious complications post major abdominal and liver transplant surgeries. Chronic illness, some evidence suggests benefits for chronically ill patients, including those with chronic intestinal failure or inflammatory bowel disease. Also, it helps in preventing or reversing parenteral nutrition associated liver disease in infants. Arginine, normally a non-essential amino acid, but becomes conditionally essential due to increased demand. However, supplementation in parenteral nutrition for critically ill patient remains controversial topic. So potential benefit can be improved immune function, as low arginine level can impair T lymphocyte function. So, supplementation might help there. Enhance wound healing. Arginine as a precursor for nitric oxide plays a role in wound healing by promoting vasodilation and tissue oxygenation. So one can see its role in wound healing. Benefits in specific populations such as surgical patients and premature infants also. Controversies and risk, we need to consider these very, very important before we go ahead and supplement patients. The debate surrounding arginine and PN has been the center of concern. Now, potential harm in sepsis. Excess arginine could lead to an overproduction of nitric oxide, causing excessive vasodilation and potentially worsening hemodynamic instability. So some earlier studies even suggested higher mortality in certain subgroups of septic patients receiving arginine. Unstable hemodynamics, arginine is generally not recommended for hemodynamically unstable patients, as it can be toxic to gut lining when perfusion is poor. Combination formula. So most of the studies done on arginine is in combination with other immune modulating nutrients. To say how effective only arginine supplementation can be is still a debate. Now, trace elements, again, is very, very, crucial, very, very discussed topic, but again, very debatable. Commonly supplemented are zinc, copper, manganese, and selenium. Of course, the dose is to be adjusted as per patient's clinical condition, duration of PN, and organ function. Dosing is highly variable and depends on patient's age, weight, and specific medical condition. Now, increased requirements could be with in patients with excessive gastrointestinal losses like diarrhea, ostomy output, burn, sepsis. Decreased requirements, patient with liver dysfunction or cholestasis requires reduced or no supplementation of copper or manganese as they are excreted primarily through bile. So this is tabular representation of the trace element, the doses, specific conditions, and the monitoring one should consider. So if you see the daily dose, it says it varies and there is no fixed dose, but we need to consider them under special cases. For example, zinc needs can increase significantly with high GI losses, as we mentioned. So, but we need to monitor the serum levels and then supplement with zinc. Similarly, copper and manganese, these are excreted via bile. Reduce or omit in cases of cholestasis or liver disease to prevent accumulation and toxicity. Monitoring serum levels is the best thing and supplementing accordingly. For manganese, whole blood manganese is the best marker. MRI may show brain deposits in cases of toxicity. So in cases where you require an MRI can be seen. For selenium, requirements can increase in critical illness, burns, and malabsorption. Deficiency can cause cardiomyopathy and muscle weakness. So look for plasma serum levels and supplement accordingly. Chromium routine supplementation may not be necessary due to contamination in some PN products. So the PN that we use for patient can also have some amount. So routine supplementation is definitely not needed. Iron rarely added directly in PN because of stability and compatibility issues with fat emulsions. Monitor serum ferritin, transferrin saturation, and hemoglobin, and then supplement accordingly. The next is vitamin. Very, very much required. Requirements of vitamins are higher than those of those required through oral enteral administration due to the following reason. It could be vitamins supplemented orally are generally absorbed much more than most trace elements. They require in higher amounts. Vitamin gets degraded during preparation and storage. For example, riboflavin and vitamin K are degraded by light, and thymine is degraded by sulfite ions used as preservative for amino acid solutions. So giving it in combination might not suffice. What the guidelines say, it could be given as a single dose multivitamin on a regular basis to patients on total parenteral nutrition. Commercially available aqueous multivitamin preparations provide normal daily requirements for most vitamin, except for vitamin K, which can be given as needed, as indicated, as a separate element. Now, these are the different nutrients required, their requirement on a